Do I really need a dental light? Okay, I've got to tell you that this video will get in the weeds faster than almost any video I've ever done. And in some ways, it really is not a talk about intraoral lights, it's a talk about loop use. However, usually the history of something tells us how we arrived at our current viewpoint. So let's think about that for a minute. First, loops were introduced to supplement visual acuity on top of what were not that great 1500-foot candle dental lights back when. Early loop lights were uncommon and they were pretty terrible. I actually had one with a giant box on the wall and a big heavy cable to feed the light over your head. Really, it was horrible. But the light really helped supplement that not so bright dental light. As loop lights got better and less bulky, it became reasonable to ask if we really needed intraoral treatment lights. And salespeople for the much more expensive loops jumped on that and began to tell you that you really didn't need to pay for a treatment light because the loop now had all the illumination that you needed. This is absolutely true for a certain number of doctors, and I'll clarify which type of practitioners those are. But in terms of the science behind this and the practice management proof and real-time four-handed dentistry, well, loop manufacturers who aren't dentists straight up made that up, that nobody needed lights anymore, and they didn't do that with any data. So my answer to the question of do I need a dental light is yes and no. You need to decide for yourself based on four factors: how you use or intend to utilize assistance, how much multi-procedure care you provide, how long your procedures are, and whether or not you're going to be working in the evenings or do any sedation work in practice. Let me simplify this right now as much as possible, starting with assistance. You absolutely can get away with not having an intraoral light if you don't intend to use CDAs or EFTAs to the full extent. Most dentists graduated from school have never been taught how to properly use an assistant, and therefore paying for something that you're not using makes the expensive top quality assistants less than desirable, and when you add the cost of treatment lights on top of this, the cost looks prohibitive. On the other hand, if you use well-trained assistants often and frequently have them cross from the assistant side to the doctor side, then they either cannot use loops on the assistant side or need a lower power, higher depth of field loop set to make this work. You can do it, but there's a specific way to do it right. I'll do a video on this at a later date. Subscribe to our YouTube channel to make sure you don't miss that. Next, if 90% of your work is single tooth, as for example in endo, the limited field of view of a higher powered loop is fine. However, if you work cross-arch frequently, as with paralleling bridge prabs or implant placement, you're at a great disadvantage in not being able to view the full field of view extremely well. The only way to do that is with a dental light. Last but not least, if you don't do sedation or anxiolysis and only treat non-anxious patients, the patients that you'll be treating are much less affected by bright room light. The bright room light is necessary to make loop-only viewing reasonable. Our users who perform sedation find it very helpful to be able to dim the room lights, at least for induction, but many practitioners that use primarily nitrous or oral sedation keep the room lights dimmed for much or even the entire procedure. This makes intraoral treatment lighting imperative. So there you have it. Lower skilled assistants treating mostly single tooth dentistry, shorter procedures, no sedation or anxious patients. In those situations, skipping dental lights is pretty much fine. If you do mostly ortho, fine. If you're an endodontist, you're going to use a ring light on your microscope anyway. So thanks to all of you guys that fit those categories. Feel free to avoid dental lights and have fun skipping the rest of this video. But for anybody that practices with extraordinary dental assistants or hopes to in the future, anyone that commonly performs larger cases with cross-arch ramifications, or any doctors that treat anxious patients, perhaps with sedatives, let's figure out what you doctors should do. Let's focus on the doctor-assistant interaction first, because it's essential. I promise to talk at length about loops and what you've been taught that's totally false in the near future about that in a follow-up video. But here's the essential bit for this discussion. If your assistant needs to shift from chair side to the operator stool, the focal length is very different in those two locations, 6 to 8 inches. An assistant working with loop lighting only has a significant challenge in safely controlling the entire field in that situation. When in the assistant's seat, his or her loop and light is not in the right position and doesn't have the right focal length. Now let me clarify. If you're doing everything with a rubber dam, safe evacuation and airway control are less critical. But most doctors doing bigger cases of any sort involving multiple specialties at once cannot work that way. To be able to illuminate the entire mouth well, you need a dental light. Now I know that there's another school of thought that has told you that you can use an in-mouth intraoral illumination to light up the whole mouth. But here's the essence. Lighting works when it's parallel to your field of view, not in opposition or perpendicular. Staring at light bulbs while successfully illuminating an area is a horrible way to gain visual acuity. And that's what having the light in the mouth does. There are some companies that yell at me a lot about this statement, but it's just physics. I promise I'll cover that in details when I get to this common misperception about loops and positioning. At the end of the day, I'm a huge loop proponent if they are carefully used in a specific way. When you don't do this, you wind up with loops that increase the problems of your ailing back, and you have an assistant team that can't grow to their potential, and you'll wind up with no more productivity than you had before you got the new high-powered loops. So now, what about that intraoral light? Even if it's only for the big cases or dentures where the patient is sitting upright, where the patient ought to be for bites, try eating while lying down. Here's what I want you to do. Try to look through your prism loops to get the required intraoral light while taking those records with the patients in the upright position and you standing up. Maybe you have some way to do it with your 20-something-year-old eyes and back, but my bet is that you had totally inadequate removable prosthetic training in school, and so nobody clearly explained to you why you should have the patient upright while taking these records in the first place. So why do some doctors hate the idea of spending money on intraoral lighting? Here goes. Pole mount lights bounce with the chair and are pretty hideous aesthetically if you're trying to make your practice look non-clinical. That's not the way to do it. Point ceiling mount lights get stuck in odd rotational positions and tend to be a hassle to move around. Wall or cabinet mount lights have long arms and tend to drift. And traditional track lights get out of adjustment and have sticky cables that wear out in their tracks. When I decided that all of this hacked me off and that I needed to create a perfect room light for shade matching anyway, and that I wanted that light to improve patient comfort, and I wanted a room light design that would reduce operator eye strain, and there's another thing you need to know about. It's called the accommodation ratio. Man, there's a lot that nobody teaches us in dental school. And it's actually really important stuff for a successful career. I mean, think about it. Eye-hand coordination. That pretty much says it, right? In terms of what we do. We don't say you need smell-taste coordination or hear-say coordination. It's eye-hand coordination. And that means you need the best lighting possible for the best coordination possible. But I guess that if the average dentist produces in the low $400 per hour, they should be able to do that much dentistry with a flashlight on a bungee cord or something. Anyway, here's what we settled on regarding high-performance lighting. We started by focusing on what doesn't work. We're never going to make a pole light great when they get in the way. We think that traditional cabinets are just plain dumb. If you want to save money somewhere, don't buy those. So no reason to spend a bunch of time on improving their light drift issue when the real problem is the stupid cabinet. Ceiling point mount lights will always have the rotational issues, and it's compounded if you do any work with the patient sitting up or if you're using a traversing chair. You should be using a traversing chair, by the way, but you probably don't even know that they exist. So that leaves track lights. Here's what I hate about the existing track lights on the market. They're too expensive. They're too hard to install. They're easily thrown out of adjustment. And after a decade of use, they become unreliable and a pain to service. But if you can get one set up and adjusted right, they're amazingly flexible and produce tremendous illumination anywhere in the mouth. So we went out and fixed all of those problems that have hampered tracks forever. Don't be impressed, it took us 5 years. What did we do? First, When you cast the chassis in one piece instead of screwing a bunch of small strips together, it can't get out of adjustment, ever. Second, if you create a patented system to mount them, you can even install the thing yourself, one person. It's that easy. Third, when you create raceway tracks inside the solid chassis, you can utilize industrial chain carriers to manage the cabling. They're proven to run 50 years worth of cycles in a dental setting, probably more. And last, if you eliminate the middleman, even with the much more expensive design, your cost still comes down. So do you think you need a dental light? I'm thinking that if one good crown and bridge case pays for all the lights you'll need, that answer is probably yes. I'm also thinking that the guys that are set on producing $400 an hour forever instead of double, triple, or even more, those guys probably quit this video a long time ago. So if you want to learn more about great tips on how to prosper in your dental practice, subscribe to our YouTube channel. We'll tell you some things that frankly they should have taught us in dental school. If you have any other questions, please reach out to my team. And thank you.